Hi, I'm Professor Poole, and welcome back to Rosie the Riveting RN. I am a nursing school professor, and I am here to help you understand the hard concepts that are taught in nursing school, and hopefully I can help you learn it in a little bit of an easier, more condensed way. So today what we're going to go over magnesium. So let's dive into it. Why do we need magnesium? We need it for DNA synthesis. We need it for carbohydrate metabolism. We need it to regulate our blood pressure, as well as having good muscle contraction and relaxation. So those are good key terms to remember. Of course, there's other things and reasons why we need magnesium, but those are basically the key points. Now, what are your ranges, your healthy ranges for magnesium? It's going to be 1.3 to 2.1. Now, your textbook might vary a little bit in that area. You may even go to a hospital for clinicals and their normal ranges may be a little bit different, but it is still the same exact ballpark, right? We're not going to treat someone with a hypomagnesemia of 1.2, right? We're just going to have them eat a little bit more foods in magnesium, right? It's not going to make that big of a deal. However, if they're really off, high or low, then yes, we are definitely going to be treating it. So just know that those ranges are really ballpark ranges. Now, let's get into hypermagnesemia. Hypermagnesemia happens because you are either eating too much high magnesium containing foods or beverages, you have too many high magnesium containing laxatives or antacids like Tums, milk of magnesia, there's another one, Maalox is a really popular one that is very high in magnesium. Or you may have renal sufficiency. So it's the basic run of the mill, like why you're gonna be high or low in something. You're usually high in something as far as your electrolytes go because you're either not, you're eating too much, you're not peeing it out, or it's moved from the cell and it's in the bloodstream, increasing the concentration of your bloods, whatever it is containing to those, that concentration of whatever we're looking at for those electrolytes. So hopefully that makes sense. So hypermagnesemia, what does it look like? A big NCLEX tip is going to be DTRs. So those deep tendon reflexes are going to be a really key thing to really look out for when you're reading questions and you're assessing your patient. DTR, deep tendon reflexes. Now, they're going to be low, meaning you're going to be flaccid, right? Your patient's going to be flaccid. You're going to try and have them contract their muscles. They can't do it because there's too much magnesium in the blood, right? The concentration of magnesium in the blood is too high. Also, what's going to happen, your blood pressure is going to drop as well as your heart rate. Now, the reason why is because magnesium helps with muscle contractions. Well, guess what? Your heart is also a muscle. So when there are high amounts of magnesium, your body relaxes too much and it can actually cause cardiac arrest and it can cause respiratory arrest as well. Now, GI symptoms, you can have nausea and vomiting as well. You can have urinary retention. And so you're going to see those in your patients. So what are you going to do? You want to monitor their vitals. You definitely want to make sure that they're a fall risk, right? Everybody in the hospital is a fall risk because they're very weak. If they have really weak deep tendon reflexes, they're not getting up, right? And you're very closely monitoring their blood pressure, right? And their mentation as well. So what is your treatment? TX. I don't know if you guys can see that, but that's treatment. TX is just shorthand for treatment. You might see that in clinicals, in notes, once you go to your clinical settings. So what do we do to treat high amounts of magnesium? Well, you're too high in magnesium, therefore we're going to limit and restrict the amount of magnesium that you're having, right? So if you are taking milk of magnesia, Tums, or Maalox, you're gonna stop it. right? You're going to stay away from foods that are really high in magnesium as well. That's going to be nuts, some leafy green vegetables. I believe kale is one of them, right? Just to name a couple of things. We're also going to give you fluids and diuretics. Now, in order to do this, you do need to make sure that the patient's renal system is functioning appropriately. So you're going to look at their BUN and creatinine, and you're going to look at their glomerular filtration rate. If their renal system is not functioning well or properly for whatever reason, what are you going to do? You're going to do dialysis. And you're going to do dialysis for any patient that has any really high electrolyte that's dangerously high, or they cannot pee it out. You're going to do dialysis for that. It's going to be hemodialysis. It's going to be dialysis through the blood. If the patient is symptomatic for cardiac signs and symptoms, what are we going to do? We're going to give them IV calcium glutamate, and I'll get to why in just a couple minutes. Now, calcium glutamate, this isn't necessarily going to be treating the high magnesium. What it's going to do, it's going to counteract what high magnesium does on the heart. So remember, high magnesium can drop your blood pressure and drop your heart rate and can cause cardiac arrest. Whereas calcium, we give it through the veins in the blood, we increase the blood's concentration of calcium, and it increases the muscle contraction of the heart. So basically what we're doing, we're giving IV calcium glutamate to keep the heart perfusing and pumping, because what is worse? A heart that is not really perfusing or a heart that is really perfusing? A heart that's really perfusing is better than a heart that is just very weak status, maybe pumping things out. So that is your magnesium, your hypermagnesium in a nutshell. Now let's talk about hypomagnesemia. You can be hypomagnesemia because you're in a starved state. You're not taking in enough magnesium containing nutrients. You're not taking in supplements. Maybe there's something wrong with your GI tract and you're not absorbing that nutrient very well. Or maybe you're on TPN and lipids and that IV nutrition is just not giving you enough magnesium nourishment. So that can be why you can have low magnesemia. So what are your key assessment skills that you're going to really look at that's going to tell you that patient is hypomagnesemia? It's going to be increased deep tendon reflexes. Remember that DTR is deep tendon reflexes. They're going to be really tight, right? Their muscles are going to be contracted. Their tendons are going to be really tight. You're going to do the reflex test and they're going to be really brisk. Remember that from health assessment? They're also going to have the C and the T. Now I call the C and the T. This is the Shavasana, where you tap the cheek and it contracts, or you have the blood pressure on the patient's arm and you you increase that pressure in the blood pressure cuff, and your tendon here contracts, right? Remember that movie Dodgeball where Ben Stiller comes out of the to the dodgeball arena and he and his little buddies are doing the clap, clap, tss, clap, clap, tss. Remember the T's? I tell my students the C's and the T's are going to be what you're going to see in hypomagnesemia. Now, also what you're going to see in hypomagnesemia is increased blood pressure, increased heart rate, and dysrhythmias. So you may want to put on a tele, get an EKG on the patient, and monitor them very closely. Also, what can happen, because your lungs have muscles around them, it can actually increase your respiration rate. So that's also another assessment you definitely want to look into. Because magnesemia helps with muscle contraction, it's going to cause you to have muscle cramps. So you're going to have pain because of muscle cramps. You can have muscle cramps throughout your body, but particularly in the legs is usually where we see it. Psychosocially, they can be very confused. Like they very just not aware all of a sudden. And so you definitely want to take that into account, and you want to work fast and find out what is going on in the patient. Now, you do your labs, you do your assessment, you find out, okay, the patient is low in magnesium. Well, now what? So things that we're going to do, we're going to increase their magnesium diet, right? The amount of magnesium in their diet. We want them to have those nuts, those leafy greens. I believe bananas even have magnesium in it. Any food that has magnesium in it, they are good to go to eat. We're also going to give them supplements, whether it's oral supplements or like a powder form that they can just drink it. Either way, that's still oral. We're going to give that to them. If they are symptomatic, or if they're very low in magnesium, or if they also have hypocalcemia attached to that, they're low in calcium as well as magnesium, what we're going to do, we're going to give IV magnesium sulfate. Now, you give IV magnesium sulfate the same way that you give IV potassium. You give it slow and low over 2 hours, and you're going to always give it through an IV pump. You never ever give it just to gravity, and you're never going to do an IV push of magnesium because it can affect the heart really bad. You can potentially put them in a cardiac arrest, which we don't want. So you may have noticed that calcium glutamate and calcium have come into discussion with magnesium. Now, there's a reason why. And this is kind of like throwing in another wrench to make things even more confusing. But it is true, and it is good to know that calcium and magnesium clinically look the same. Did you know that hypocalcemia and hypomagnesemia looks the exact same? And hypercalcemia and hypermagnesemia clinically look the same. Now, that does not mean, to throw another wrench into the playbook, that does not mean that anytime you have low calcium, you're automatically going to have low magnesium. It's not that way. It's just that clinically they look the same. But there is something that we can do in our assessment skills that can tell us, hey, this is probably going to be magnesium and not calcium. And what is that? So basically, they look the same, but how they affect the heart sets them apart. So think of the maternal mama, right? The maternal mama. You have the mellow magnesium is mama's favorite child. Chaotic calcium makes mama's cardiac wild, right? So what does that mean? So imagine a woman she had twins, right? One is magnesium, one is calcium. She loves them both, but a little bit the same. We've all, we've had those favorites in the family, right? So magnesium is the favorite. It's mama's favorite. It makes magnesium mama so happy, right? She is calm. She is happy. She's content when magnesium is around, right? When magnesium is high in the blood, it calms the heart down, right? When magnesium is high in the blood, it calms the heart down, and it can cause it to be a little too calm, you know what I mean? However, then you got that chaotic kid, right? That just drives you nuts. You love them, right? But you can only take them in doses, and that is calcium, your chaotic baby, right? You love them, but you can only take them in little doses. That's calcium, right? A high amount of calcium is going to make the heart go choop wild. It's going to make the mama have dysrhythmias. High amounts of calcium increases the blood pressure, which is why we give hypermagnesemia, IV calcium glutamate, when the patient's blood pressure starts to tank. We need to increase the blood's concentration of calcium to increase the conduction of the heart. Now, another thing that I teach my students is kind of remember the pregnant patient. The pregnant patient does get magnesium when they are having contractions too early, or if they're getting treated for preeclampsia. Now you get into that a little bit more into L&D. I'll just tap into a little bit to hopefully make another connection for you guys. So imagine a preterm mama, right? And she's in labor and it's just way too early. And if only we can get the baby to stay in the mama's tummy for a little bit longer, it'd be better for the baby and for the mama. So we want her to stop contracting. So what do? We give her IV form of magnesium, right? Magnesium. And so that increases the magnesium concentration in the blood, making that uterine muscle relax, right? High amounts of magnesium relaxes the body. Magnesium makes mama mellow. Calcium makes mama chaotic, right? So you just want to kind of remember that. Hopefully that helps. We're going to get into more topics. Please like, rate, subscribe. Thank you so much for joining me for this lesson. I hope you took something away. I hope I was able to condense some things for you and make it a little bit easier to understand. And remember, the best medication is patient education. Bye-bye.